Good morning. Today's lecture is on sympathetic ophthalmia. How we will define sympathetic ophthalmia. It is bilateral granulomatous panuveitis occurring when uvea of one eye is subjected to penetrating injury due to either accidental trauma or surgery. Injured eye is known as exciting eye. Fellow eye who develops inflammation after days to years is known as sympathizing eye. Sympathetic ophthalmia is found to be associated with specific HLA haplotypes, which would suggest that in some patients there is a genetic predisposition. But the most common cause is trauma. Incidence is probably 0.2 to 0.5% after injury. Multiple intraocular surgeries can also cause sympathetic ophthalmia. On histopathological examination there is diffuse lymphocytic infiltration of choroid. An important finding is Dallen-Foucault's nodules, which are granulomas located between Bruch membrane and the retinal pigment epithelium. In 65% trauma-induced cases, patient Hussain Ahmad presents between 2 weeks to 3 months after initial injury. The exciting eye is frequently red and irritable. The sympathizing eye develops irritation, blurred vision, photophobia, and loss of accommodation. Patient with sympathetic ophthalmia can have red eye with anterior uveitis in both eyes. That is mild or severe in intensity and usually granulomatous. The severity of inflammation usually asymmetrical. On fundus examination there are multifocal choroidal infiltrates in the mid-periphery with sub-RPE infiltrates corresponding to Dallen-Foucault's nodules. There can be exudative retinal detachment, vasculitis and optic disc swelling. As inflammation settles, residual chorioretinal scarring confer a sunset glow appearance. Prognosis depends on severity and location of disease. Response to treatment. With aggressive therapy, 75% of sympathizing eyes retain a visual acuity of better than 6/60ths. Long-term follow-up is mandatory because relapses occur in 50% of cases and may be delayed for several years. The following investigations are useful in diagnosis, monitoring of disease progression and monitoring of treatment response. Optical coherence tomography is useful for quantifying and monitoring change. B-scan ultrasonography may demonstrate choroidal thickening and exudative retinal detachment. Fluorescence angiography shows multiple foci of leakage at the level of the RPE, with subretinal pooling in the presence of exudative retinal detachment. ICGA shows hypofluorescent spots in active disease, which resolve with treatment. Sympathetic ophthalmia can be managed by medical drugs or surgery. In medical treatment, steroids are basis of initial treatment. High-dose oral prednisolone is given for several months and gradually tapered according to response. Initiation with intravenous methylprednisolone may be used in some cases. Supplementary topical steroids and cycloplegics to target anterior uveitis. Immunomodulatory treatment is required early in the course of the disease. Alternatives in steroid-resistant inflammation or as steroid-sparing agents. In surgical management, enucleation of a severely injured eye within 10 to 14 days of the injury has historically been considered effective in preventing or reducing the severity of disease, and it should be considered for an injured eye with a hopeless visual prognosis. Evisceration is an acceptable option provided all uveal tissue is removed. Thank you for your attention.